From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Albert Einstein College of Medicine Montefiore Medical Center and JAMA Neurology Web Editor. Joining me today is Dr. Ari Green, and we're discussing his work entitled Neurofilament Light Chain Elevation and Disability Progression in Multiple Sclerosis. Dr. Green is a neurologist and translational scientist at the University of California, San Francisco Health System, where he's also the chief of neuroimmunology and glial biology. He's interested in biomarker development. Dr. Green, welcome to the podcast.
Thanks, Dr. Armand. It's a pleasure to be here, and thanks for speaking with me.
Yes, I'm very excited about this conversation because a common scenario as a neurologist is we have a patient, they're diagnosed with multiple sclerosis, and 9 times out of 10, the first question that they ask is, when am I going to be in a wheelchair? When is my life going to drastically change? When is this disability going to come about? What do we currently know about disability progression in multiple sclerosis?
Yeah, so it's a great question. The field of MS has seen tremendous development of therapeutics that are principally targeted against the immune features of the disease and have been successful in preventing the relapses. But as you touched on, they've been partially successful, but not completely successful in eliminating disability. And that is the major unmet need in the field. And the important step before we get the answers about how to treat it is to understand the biology of it. So there's important work there, but I think the simplest way to put it is we don't really fully understand the biological basis of disability in MS.
Mm-hmm. Now, in your study, there's work with neurofilament light chains, and I'd like you to explain to our listeners what the significance of that is and how that's related to neuroaxonal pathology.
Sure. So neurofilament light is an important protein in axons of the neuron. And the exact function of the neurofilament light chain, actually part of a multimer of proteins that constitute the neurofilaments, and they are said to be important for the cytoskeletal structure of an axon. You know, an axon has this long process, and its structure is super important for its capacity to help with communication of signals. But it's not totally clear that it's a cytoskeletal protein. In fact, if you knock out a protein from an animal, there's really no major phenotype. But what's been really important to the field is the fact that neurofilament light is largely expressed in axons of both the central and peripheral nervous system. And the capacity to measure neurofilament light at extraordinarily low concentrations, and in fact, a particular peptide, a particular component of the protein that appears to be really related to neuroaxonal damage based on some recent work, allows us to look and sample and see if there's any evidence of damage either in CSF or in blood products like serum or plasma. So we can look and see whether or not there's elevation of neurofilament light as evidence of neuroaxonal injury.
Now, is this a recent development, or if patients go to centers where they're seeing neuroimmunologists, are they typically testing for something like this and determining disease progression?
Yeah, it's not typically being used. I mean, the development is relatively recent for the capacity to reliably measure neurofilament light at extraordinarily low concentrations. And there's also a lot of important developments there around how do we actually interpret the result. And then there are a number of different assays that can be used. So the one we used and the one that is most promising and most well developed is based on a technology known as Simoa. And simply put, it's just a digital immunoassay that allows you to get measurements at those extraordinarily low concentrations. There are commercially available assays, but they may use different antibodies and use different technologies and may not be sensitive to the same level. So it's really not, at this point, part of routine application for patients with neuroimmunological conditions, but in the short to medium term, it might become increasingly important in the management of patients.
So tell us about your study objectives and what you set out to do.
Yeah, so as you touched on early on, we really need to understand the biological basis of progression in MS. And one of the views that has become semi-canonical in the field is that the biological basis of permanent irrecoverable disability is axonal loss. And there's pathological evidence to support that, but one of the limits of pathology is single time sampling, especially when you're looking at the central nervous system. So we can't know for absolutely sure, based on pathology, that it is the biological basis. It just makes sense. So the capacity in a living subject to actually measure neurofilament light is a super important development. So we set out to use two very, very unique cohorts that have both relatively large numbers of patients and long-term follow-up. So one at UCSF, known as the EPIC cohort, and another taken from colleagues in Switzerland called SMSC cohort. And these two cohorts have years of follow-up, but also have blood and serum available for us to be able to test. And the idea was to look, when is the evidence of neurofilament light elevation in relationship to progression of disability? Now, there's a bunch of nuances there, and we can get into them, but the simple question was, what's the timing relationship between this evidence of neuroaxonal loss and when patients show detectable disability that is sustained?
And this is for the cohorts that you examined. These were patients with various types of MS, correct? Rapidly progressive, primary progressive, things of that sort.
That's right. So it's important to note that the field as a whole has been moving away from these sharp distinction between relapsing and progressive MS. And there's been a lot of literature there that's helped us to see that, that old binning and categorizing of patients that said, oh, well, this patient has relapsing MS and this patient has progressive MS, as if they were almost distinct diseases, is almost certainly wrong. It's actually relapses that occur during the progressive phase of MS and progression that occurs during the relapsing phase of MS. But this cohort included subjects who had a variety of different stages of the disease because it followed them longitudinally. Both of these cohorts were derived from patients with relatively early disease at their initial entry into the studies. But they followed them for long enough that we saw people who would progress through the different stages.
Oh, great. Tell us about your methods of conducting this study and on to what you found and different aspects of how we can determine if we can answer that question to someone definitively or begin to understand how to answer that question of when we can detect disability occurring prior to manifestation.
Sure. Yeah, so there's a couple important things to think about in trying to monitor progression in patients with MS. Our gold standard for measuring it is to use the EDSS, the disability scoring scale. And it's useful, although it's an ordinal scale that kind of masquerades as a numerical score. And in some ways, it has lots of limitations, the most important of which to note is that it's not really all that granular. People can have decline in their activities of daily living or function, and they won't score any different on the EDSS if they don't change which bin they end up in. The other part that's important to know is that sometimes because of relapses, people have worsening and then recovery. So in the field, we've come up with this notion of confirmed disability progression. So someone had a disability worsening event, and then at the next time you evaluate them, the disability increase is still there. So that's a way to really gold standard who has worsening. So we used in that cohort of the patients followed for all these years at UCSF and in Switzerland, we used the concept of the confirmed disability progression with 6 months of confirmed disability progression, meaning you measure them at one point, 6 months later, they still show the disability worsening. And then went and looked, what's the timing of when neurofilament light chain shows elevation? And most of the work that had been done previously had tried to look for coincident, like there's a neurofilament light chain elevation at the same time, which is a relatively simplistic way to think about it. From our own perspective, disability worsening like that is really a terminal event. It's an event that happens kind of at the very end, especially when it's measurable on the EDSS, and it requires potentially lots of injury to have accumulated in order for the patient to manifest disability. So that's why we look to see, well, in advance, is there any elevation? And the really remarkable thing to us was not just was there increase in neurofilament light in advance of disability worsening, it's that it happens significantly in advance. And the two most remarkable things are, we know for relapses at the time someone has worsening that the neurofilament light is elevated. But we saw that there was elevation of neurofilament light up to a year in advance of when the patient had their event of disability worsening, which is really, really stunning because it suggests that there's something brewing for a sustained period in advance of the relapse. And the other part that's almost equally stunning and important for us in thinking about the biology of progression is that for people who had worsening in the absence of relapses, so these are patients who not having any clinical episodes that would suggest inflammatory events, there the neurofilament light chain was elevated up to 2 years in advance of when they showed the worsening. And each of these suggests, kind of touching on your first initial question, disability is preceded by a lot of things happening. There's probably ways that we could better track it and identify people who are at risk. And neurofilament light could at least be part of that equation for helping us to guide patients and tell them, things are happening that are below the surface that are almost certainly not detectable by standard routine measures like MRI.
That's certainly remarkable because we think of a visit of seeing a patient and things are seemingly stable. However, the microbiology is there and occurring. And if it's something that we're able to track, we can implement certain therapies earlier, in a sense, is what I'm getting from this.
That's exactly right. And it might even also guide us to thinking about additional therapies, because it's important to note that these cohorts are actually almost all on some form of therapy for management of their MS, existing therapy, right? We have like those 20 plus therapies that are all immunomodulatory or modestly immunosuppressive that help us to manage MS. But those therapies, as we touched on at the very beginning, are only partially effective at preventing disability. And so this helps to change the equation for us in thinking about, well, there's evidence that even those patients who are on maximal therapy for prevention of relapses and inflammatory activity still have some evidence of neuroaxonal damage. And are there things additively that we could do that might target a different part of the biology of the disease that helps us to prevent people from developing ongoing and further progression?
That's great. I think that's an important direction to take, especially in treatment of multiple sclerosis and explaining to patients. And I always come to this in seeing someone who they can be doing all the right things, taking their medication, and they're still ending up with exacerbations in the hospital, still kind of declining. And I think as neurologists, we're left with, how can I further impact? And I think a study like this that gains more of this knowledge is definitely taking us in that direction of how we can positively impact this and further help.
Yeah, I think that's exactly right. I mean, our existing therapies, especially our most effective ones, are really, really good at preventing relapses from happening. They reduce them by dramatic amounts, 90% plus. But as you touched on, we still are left with people who come to us who say, my disability is getting worse. Now, the framing of that disability has changed in a wonderful way. I mean, it used to be that every patient's principal worry, especially, or principal evidence of worsening, was that they were having ambulatory dysfunction, having trouble with walking. That's not the only thing that we talk about with patients these days, because the disability spectrum has gotten less severe with the therapies that we have. But it still doesn't mean that patients aren't getting worse. They still have trouble doing activities they love, whether it's patient who loves to sew, or a patient who loves to walk on the beach, or a patient who is committed to sport and loves to mountain bike. It could be anything that they used to do that they're now prevented from doing or they do less well. And so helping them in that regard is probably our greatest charge.
It's exactly what you said. Disability just isn't ambulatory. It's living life to the fullest and being fully functional. And how has that changed on a daily basis? Where do you see this going in the future? Do you have anything in the pipeline coming up? I'm eager to hear about what's next.
Yeah, so one of the limitations of neurofilament light that many of the listeners may be aware of is something I touched on earlier, which is it's found in axons throughout the central nervous system and even in the peripheral nervous system. So it's not a perfect specific measure for damage in MS. And ultimately, neurofilament light is even part of the thinking for our colleagues who take care of patients with neurodegenerative diseases like Alzheimer's disease. So I think ultimately for many of these, there will likely be a suite of tests that are based on blood-based or maybe CSF-based assays that help us to not only figure things out better diagnostically, but prognostically in the right subset of people, that can help us to guide people to say, well, here's what your MRI shows. But MRIs, as we know, are relatively incomplete. They have a limited resolution. They can't distinguish between different types of pathology. So complementing MRI with blood-based tests in particular, because they're less invasive than LP and CSF-based tests, I think is really going to inform a generation of therapeutic decision-making in the neurology clinic. It's hard to know exactly which of the next ones are going to be most promising, but we have a lot of promising data on other proteins and peptides that we're able to measure at these really, really low concentrations. And the reason they're such low concentrations, right, is they got to get out of the brain and into circulation. So it's not like there's not much damaging happening. It's just damage happening. It's just hard to measure that damage because there's so many barriers in the way. Just like, MRI was great because it got us away from X-rays that can't see through the skull. Same way, these really, really sensitive assays are going to allow us to see stuff, get a peek at what's going on in the brain. But we're going to need multiple different assays, I think, to be most informative for individual patients. This work definitely could never have been completed without major contributions from Dr. Ahmed Abdelhak, who's a postdoc rapidly moving towards independence within my group. He has been the engine for most of the work that we've done and really a unifying force between our own group and the group in Switzerland. And that group in Switzerland, special thanks belongs to Dr. Jans Kula, who has led that group and been an international leader in the development of both neurofilament light chain and other serum-based biomarkers for monitoring disease in MS, and Dr. Pascal Bankert, who has also contributed in major ways to this analysis. Furthermore, the people at UCSF who really deserve thanks are Dr. Bruce Cree, who has helped us to maintain the EPIC cohort over many, many years, Kukita Gomez, who has been also a major force for establishing and maintaining that cohort, and Dr. Steve Hauser, who has also helped us to support and fund the ongoing EPIC study.
Dr. Green, thank you so much for joining us today.
Well, thank you so much for having me. It's a real pleasure to get to speak with you.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thank you for listening.